within an organisation or social enterprise called MedEd, for which I'm the president of that. So I'll tell you a little bit about that as well. But predominantly, I know you guys want to focus a little bit more on kind of the clinical teaching role today. So just a little bit about myself and my timeline really so far. I have a very short career so far in medicine, yeah, so basically the bottom picture down the bottom of the nice timber frame building was the school I went to in Stratford-upon-Avon, following which I headed off to University of Bristol, which is that lovely clock tower building that's being lit up there. And after my degree at uni, so I didn't intercalate while I was there. I just powered on through thinking, great, yeah, just want to make it to clinical medicine, start earning myself some money, and that would be great. And I look back now and do regret not doing that. So that's something that I wanted to touch on a bit today as well. And then I did my foundation years at University Hospital in Coventry, which is a big sort of tertiary centre, big teaching hospital, in various number of jobs kind of rotating around as you do in your foundation years, followed by my current role, which is the clinical teaching fellow job up in South Warwickshire NHS Trust, or Warwick Hospital, which is a nice local district general hospital. So that's basically kind of my timeline in terms of my medical bits. And as I mentioned, the other big part of what I do is my role as a president of MedEd. So MedEd is a very large not-for-profit social enterprise which helps support aspiring students and current medical students, and we're also branching out into junior doctors as well. So my role kind of predominantly consists of doing quite a lot of close personalised mentoring with our current students and aspiring students as well. And it's something I love because I get to do lots of big national conferences with it, and I've had lots of research opportunities, and it's just something that I'm really passionate about. And I think actually, we don't talk enough as healthcare professionals about resilience and well-being, and we think that near-peer mentoring is the way forward in terms of developing those skills as healthcare professionals. So these two pictures depict generally my time at university, particularly the one on the left. So I spent a lot of time at uni having a really good time, and didn't really focus at that kind of stage on what I wanted to do with my career. I was blissfully unaware of any kind of career in academia. As I mentioned, was quite keen on getting through and being able to practice medicine. And when I came out of that process, I kind of looked back and was like, wow, what did I actually achieve, during my 5 years at medical school? Yeah, I passed some exams, I learned a lot of skills in medicine, but that extracurricular stuff, which I felt would have been really valuable, I was distinctly average in. Yeah, so the picture on the right there is me driving a very small car on my job in paediatrics. It was really at this sort of stage, once I'd become an F1, that I realized actually there is so much more that I should have done when I was at university, and so much more that I needed to catch up on with when I started my foundation years. And at this point, really, this is kind of a good opportunity for me to tell you a little bit about what I then started doing to try and catch up in those early foundation years, really. So I started with some audits, did a couple of departmental local ones, and then started getting involved with some more national ones. So some of you might have heard, for example, of the Star Surge audits, which are these big national audits that get done, and often a lot of the data collection is done by medical students and junior doctors. And I started seeking teaching opportunities, and the reason I did was just because I've always liked teaching. I think if I hadn't been a doctor, I'd have probably been a teacher of some sorts anyway. Again, that built really from kind of thinking about small departmental presentations and teaching opportunities, working with medical students who came onto the ward, for example, and then kind of moving up really and starting to do more local kind of teaching workshops, and then thinking a bit more regionally as well. I did a little bit of the other stuff as well. So I think somewhere at some point in my early foundation years, someone told me that I could get some points on my application if I was the president of the doctors doctor's mess. So I still am to this day, because nobody else wanted to take it over, because yeah, from my experience, it's not worth the hassle, is all I'll say. And yeah, then I fell a little bit into Medic Mentor, which I've been very, very fortunate to do, because that's given me a lot of my kind of experience in medical education, really. And that was my first presentation as an F1 at a national conference. And it actually worked really nicely for me, because it was something that I felt confident about talking about. It was a presentation to aspiring students, as opposed to scary medical students whose knowledge gap, compared to myself, probably wouldn't have been that much different. So that was really how I fell into it. And then thinking a bit more about kind of in foundation year 2, a lot of my colleagues were then starting to come up with career kind of plans, whether they're going to apply to IMT or core surgical training, for example. And I was thinking, oh Lord, I'm not really sure what I want to do here. So I actually just built that. I then continued to get more teaching exposure, more audits, more research. While I was on my general practice job, did a fairly simple research project while I was there, and managed to get that presented at a national conference. I started exploring different prizes and awards on a local level. I got offered a couple of those, which was really fortunate. But as I say, at this stage, I wasn't really sure what I wanted to do with my career, or indeed, how to go about exploring that. And I knew that really I probably needed sort of F3 kind of year, because at this stage my career plans weren't really solid. And I remember kind of thinking, as a medic, I guess we're all trained quite a lot to kind of, always be aspiring to that next level. And then all of a sudden I was, that person who had no idea what they wanted to do with their life again. So it was a bit of an unusual, kind of alien feeling. But it's actually been something that I've really embraced, taking that kind of year to spend more time exploring myself and developing myself professionally. So I did a bit of umming and ahhing about differences between locums and trust grades, and the merits of each of those. And for me, the uncertainty of doing a locum post and potentially not getting much in terms of job certainty and regular shifts was a concern, whereas some of the trust grade jobs would have been a little bit more structured for me. I'd have had that kind of easy portfolio review, and making sure I was meeting all of those requirements that I needed to in order to be able to keep my GMC number and things like that. And I just knew that I really enjoyed teaching, quite frankly. I really like it, always have done. And the more I did throughout F1 and F2, the more I started thinking, actually I can make a career out of this, really. So this is my kind of my top tips, I guess, for gearing your CV towards teaching. It's stuff that you can do as a medical student and as a very early junior doctor as well. And it's simple as things like gathering certificates for everything that you do. It feels really cringe having to ask for them, but actually evidencing that you're teaching on a regular basis is really important. But that step above is gathering feedback and actually keeping a portfolio of the feedback to demonstrate, for example, your improvement and your development in your teaching skills. And that for me came in really handy, because I think a lot of developing yourself as a teacher requires quite a lot of self-reflection. Some people are inherently very good teachers, and it's just part of their characteristics and their attributes, and some people have to work on it a little bit more. And I think for me, reflecting back over the processes that I'd been through and the feedback that I'd had was a really good way of doing that. So I was quite active by this point. Finally, I'd started getting a bit active, and was searching actively for opportunities to do sort of more large-scale teaching, like regional and national conferences, which are better really for your portfolios. And I think it's really important to say at this point that if you are interested in a career as a clinical teaching fellow, or a year as a clinical teaching fellow, or a career full-time in academia and medical education, then you have to remember that it's not just about your teaching abilities. It's about your leadership skills, your ability to reflect and improve on your teaching, but also the processes at the institution that you work for. And of course, everything that's happened with the COVID pandemic, it's so much more about about kind of innovation and advances in technology and how we adapt, for example, of course, to the virtual environment. So clinical teaching fellow applications, for me, it was quite a long application. It needed a CV, needed lots of evidence for that. It was a very competitive process and not one that I'd expected to be quite as competitive. I actually applied for a couple of clinical teaching fellow jobs because I wasn't really sure. I always had my sort of eye on the Warwick job because it was kind of very local to me. But I did go to some other ones, and actually the one I went to at Birmingham City and Sandals was a very rigorous interview process, taken extremely seriously, with multiple panels, and they explored all aspects of my medical career during that time. So there was lots of kind of case scenarios, role plays, etc. So it was quite a rigorous application process. And yeah, I think it's kind of important when you're thinking about clinical teaching fellow jobs is that consideration of a clinical versus non-clinical split, really. For me, I wanted to make sure that my clinical skills were kept up to date. I didn't want to do a full-time teaching job because I wanted to make sure that I wouldn't lose my confidence really in that. I'm inherently quite a sort of anxious clinician, and I worry about a lot of things when it comes to my clinical skills. So I really wanted to make sure that I was continuing those. And the best way to do that for me was to sort of have a roughly 50-50 split. But there are clinical teaching jobs out there that are completely full-time, and the varying ratios, basically. So there are some other things that you can kind of bear in mind. So there are other academic posts and clinical teaching jobs that you can, or clinical fellow jobs that you can consider if you want either a year out or if you just want to get more heavily involved in kind of academia and education throughout your training. So some of the kind of academic clinical fellowships that you can do as part of training programs are particularly good if you want to keep your clinical skills up, but they are quite research heavy and you might not have quite so much self-development time. You have the kind of fixed term year contracts in certain specialties with a big academic emphasis on them. And they're often sort of like a clinical teaching fellow year, but they tend to be more research and not teaching. And yeah, I think those, again, they have their merits. There's lots of dedicated research time, there's lots of funding allocations for them, and then loads of different specialty specific ones as well. So I'd recommend having a look at the NIHR website if you're interested in those sorts of posts. But for me, as I say, my heart was kind of always set on the teaching aspect, and that's why the clinical teaching fellow job just fit really well for me. Alongside that, I had a couple of friends who were interested in it as well, and so it actually became something that I chose, for the merit of it, of the lifestyle, I guess, as well. Of course, the pandemic hasn't made it sort of a particularly predictable experience, shall we say, or the typical clinical teaching fellow job, which might be, you do some teaching and then you head off down the pub for a nice drink in the pub garden or something. So that hasn't happened, but I still live in hope. But yeah, so this is a kind of rough day in the life of a teaching fellow for me anyway, and they may well vary. But we obviously have our clinical and our non-clinical split. I am on the general medical rota, so I'm on a full, the equivalent of the full gen med rota on call, which means I still do nights, I still do twilights, I do all the other kind of clinical duties, but my sort of rough 9 to 5 part would be teaching. I do a lot of bedside teaching. In fact, today I've been doing some examination of some final year students and taking them to see patients at the bedside, and we also run lectures, workshops, all of that sort of thing. And as I said, yeah, quite heavily involved in the assessment, and you get specific training in those particular clinical exams, which has been really useful for me. I didn't, previously to this, I'd done lots of teaching kind of, to improve my CV, but hadn't really been involved in assessment and examination. So that's been something that's been really, really interesting for me. And I've done a lot of curriculum design with it as well. So as the lead for the revision blocks for both of the universities that are present at my hospital, so that's Warwick and Buckingham medical schools, I've kind of been able to, get some experience, I guess, of designing curricula, and the pros and cons that come, from that, and how to adapt everything, as I've said, into the virtual learning environment as well, has been a real challenge for me. We do sort of weekly journal clubs. So we're quite lucky that we get experience to be come together and sort of explore scholarship as part of medical education. And yeah, I also get my PG cert paid for by the trust, so they'll actually fund master's modules. Now I know it wasn't a thing in my day when I was at medical school, but I know that they're now doing intercalated degrees and stuff in masters in medical education, which is a really amazing opportunity for those of you at medical school. But for me, I'm having to work through mine slowly part-time alongside my other duties, so I am working towards my masters. And as I said, moving forward for me, having told you all about my lack of career uncertainty to this point, I can confirm that I still have a lot of career uncertainty in terms of where I want to go. And I've thoroughly embraced that, I must say. Having done a year as a clinical teaching fellow, I've realised that actually I love medical education. I would quite happily do that full time, but I can't quite give up my clinical side of things just yet. So I'm still a bit unsure. I also enjoy public health and things like that. So, and I think that's the key with these years and spending time in a bit of academia or education, is that you get time to develop yourself, time to develop your CV, and think about what you want out of your career. And as I said earlier, you know, I was very much of the mindset you have to rush through everything and you know, you're in that rat race to become a consultant or something. But times have changed, and actually it's really nice to stop and enjoy the journey as you go along. And I'm quite happily enjoying that at the moment. So I'll finish my masters. I'm doing a public health community fellowship as well, so I'm getting a bit of time to do that, and just exploring research and getting some of those publications going forward specific to the field of medical education. So that really it kind of sums things up. I think it's important to think about the benefits of academia. Remember that, you know, it doesn't always have to be a career. It can just be a year doing something. It's time for self-development, and of course those important transferable skills that I mentioned: leadership, quality improvement, teamwork, that you get to explore more. And I think you do develop some insights that, you know, into the learning process that are useful in your clinical practice. And it's just something a bit different. You know, if you're unsure, my CEF year has been a really, really good way of confirming to myself that actually definitely medical education is the way forward in terms of my career. So yeah, I hope that answers some of the questions that you might have had, but if you have any more, then I'll stick around. Thank you for listening.
Thank you so much. That was really interesting to hear your journey so far and how you're planning on moving forward. So if we don't have any particular questions at the moment, we can move on to our next speaker, which is Kish.
I've got a question.
Oh, go on.
That picture, was that? Are you sure that was your school? It looked a bit like Anne Hathaway's cottage to me.
It's very close to Anne Hathaway's cottage. My school was literally around the corner. So that is I think it's called Shottery Manor, which was the building, interestingly, that Shakespeare and Anne Hathaway got betrothed in. So they had their betrothal ceremony there. So that's a little bit fun fact, some history for you. But yeah, just around the corner from Anne Hathaway's cottage. You're quite right.
Any other particular questions? That's fine, Kish. You're welcome to start sharing your screen and stuff. So Kish was a CTF in the university last academic year, and he's come to talk to us about his journey in medical education.
Cool. Hello, everyone. Nice to see some familiar faces. Not places. I don't have any Anne Hathaway related memorabilia in my presentation, unfortunately. Sorry, guys. So yeah, my name's Kish. I was a CTF at Leicester Med School last year, and I'm going to talk in a similar vein to what Olivia spoke about. So sort of the flavour of medical education, what you can be doing now and in the next few years to improve your CV for future possibilities. So who am I? So I'm local. I'm from Loughborough. I went to King's, graduated in 2017. That's me, next to Keats over there. Actually, yes, I've got a historical feature of Keats, which is, you know, Anne Hathaway, Keats, you know, tomato, whatever. I came back to Leicester to do my foundation training, so I spent 2 years here, and then I was a CTF at the med school for 1 year as well. Currently, I'm a trust grade in the Leicester Royal Infirmary Emergency Department, and I'm applying for emergency medicine, so hopefully we'll have a training place from August. I'm currently also working as an honorary teaching fellow, and I'm doing some work with Liz Anderson, and I'll come on to that a bit later on. And the plan is to be an ED consultant with a specialist interest in education. So some sort of element of education within my future life. Cool. So a meme to sort of, get you involved and looking at the screen. Yeah, emergency medicine, really good fun, very varied. Not as stressful as people may think, but yeah, if you want to ask any questions about emergency medicine, I'm more than happy to answer as well. So what I'll be talking about is why I'm interested in, I guess, teaching, but more specifically medical education. My year as a CTF, what I've done to bolster my CV for medical education, and there's some things that I'll sort of take as examples. And I've also got some tips sort of involved in that. Quite similar to Olivia's talk, so maybe a different edge on things, but I'll try not to overlap too much. And a bit of a disclaimer is that I don't think there's sort of one route in. There's lots of different ways of getting into medical education, and I also think there's no, one aspect. It's not just teaching. It's not just research. It's lots of different things. So it's whatever takes your fancy. So why I enjoy MedEd? So I think I really enjoy getting to know people and watching them progress. So I think that's medicine essentially, but also a great deal about education. I think what's great about teaching is that you can be very creative with what you do when you are teaching. So, medicine has so many different facets to it. You have the clinical side, you have the theory side, and teaching that and purveying information in a certain way, you can be very creative with how you do it. And in that vein, there's lots of different aspects to medical education. So whether that's, admissions, assessments, research, teaching face-to-face, giving lectures, there's lots of different parts of medical education within a med school, which is something quite exciting and varied. And I really like variety. I think I get bored quite easily. So it's something that I really enjoy about medical education. And it's also a great way to learn things. I think, I spent a year essentially doing year 1 and year 2 medicine all over again, and, learning anatomy again, learning neuroscience again, pharmacology, physiology, and that really helps me in my clinical practice. Stroke detection, I'm much better at, and identifying the lesion, thanks to sort of hours spent with Steve Jakes going through neuroscience stuff. So, it's a good way to learn things, because teaching is one of the best ways to learn. And then also it's a change of pace. I just think that whether it's something that you do 1 or 2 days in a week, or whether it's something that you do for a year, I find that you go back to clinical medicine just feeling a bit more refreshed, a bit more hungry. So it's just a nice way to change things up. So clinical teaching fellow jobs, there's lots more across the country now than previously, and they vary quite a lot. So I just Googled some today, and there's one for obstetrics and gynecology if anyone's interested. But they vary depending on sort of what stage you want to go into them, how senior you are, whether it's more classroom based. So the one at Leicester Med School is much more classroom based. There's another one at the UHL Trust that's a lot more hospital based and is more about research and audit. It's a really good way of getting a taster of medical education. So if you're not sure, or if you enjoy teaching but you're not 100% sure whether it's for you, it's a really good way of just feeling out there and seeing what there is, because often you'll find something that interests you. And what's nice is that it's often associated with a formal teaching qualification. So we do the PG cert at the med school when I was a CTF last year, and that points towards pretty much everything. So if you're applying for any specialty, a formal teaching qualification is really handy. But it also just gives you that theory to back up your teaching experience. And I'll talk a bit more about that on the next slide. It's also often when you sort of go into a teaching fellow, there's always lots of projects going on regarding education. So it's a good way to get some research under your belt, which is quite sought after in any field. Even if you choose not to go into MedEd, having some research under your belt is just really handy for any specialty training that you do. And I've put the future in quotation marks because to me, I think being a teaching fellow, the way that Leicester has done it just makes sense to me. I think having doctors that have gone through the process, have worked clinically, and then have come back to teach medicine just makes sense to me. I imagine that we'll see a lot more clinical teaching fellows in the roles that we have in Leicester across the country. And just to finish it, I don't think it's the be all and end all. So I don't think that you have to be a teaching fellow to then go and progress in medical education. I think there's lots of different routes into it. And it's not just you have to be a CTF to then go into medical education. It's just one of the routes. So my experience and what I gained, I think the reason that I chose the one at Leicester Med School as opposed to the UHL Trust CTF job was because Leicester had a lot more face-to-face teaching, and that was what I really enjoyed. Obviously got to do a couple of lectures, which is really good, sort of a good skill to have, and a good buzz from it as well. And I think what's nice is that you really get to embed and understand the workings of a medical school. So, I took part in the admissions process, so sort of thinking about MMIs, obviously worked with giving small group teaching, lectures, working with module leads. You then think about assessment. So we did like standard setting, writing questions. So you really get a sort of a full idea of exactly what the workings of med school are and the hierarchy and who does what. So I think that's something that's really important if you're interested in that vein. And so the qualification, so the PG Cap or the PG Cert, and then the fellowship of the Higher Education Academy. So essentially this was a 1-year course where you gain this fellowship with HEA, which is a nationally and internationally recognized qualification, so that you could take it almost anywhere and the university would be able to say, oh, okay, he's an FHEA or she's a senior FHEA, and it just shows that you've got that qualification. And essentially what it consists of is writing a reflective essay, doing some observed teaching, doing a project which incorporates some educational theory, and writing about it, and then it's all assessed through coursework, and then you sort of graduate with an extra I guess letters to your name, and some more knowledge. And I think I briefly touched on this before. So doing this teaching fellow job really improved my own medical knowledge. I was really lucky in the sense that I had to do a medicine exam a few months after doing the CTF job, and I managed to do quite well just because I'd essentially gone back to med school for a year, learned everything I needed to know, and then sat this exam. And often a lot of specialty exams, so medicine, surgery, emergency medicine, will always have like their first exam will be like basic sciences or first principles. So it's a really good way of just sort of recovering that information. And then the last 2 points kind of just relate back to what happened with the COVID-19 pandemic. So whilst it was not ideal, terrible, many words, there was a silver lining in the sense that I became quite proficient using things like Blackboard Collaborate, teaching on Zoom, and also we got to design and make resources for the 3rd and 4th year clinical students, and that was challenging but really interesting because we were working with our own module leads, but also the clinical leads in the trust, and we made new resources, made all sorts of weird and wonderful things, but it was a really good experience for myself. Yeah. And then I think I can't talk about being a CTF without talking about the team. So so much fun. I think what's different about working on the wards compared to working in an office with 12 or 13 people that you get on with is just everyone's always around. If there's nothing to do, you find things to do. So we had a lot of fun. The top right picture is one of the current CTF still, but she wrote a quiz for us. I think it was before Easter break, and she wore a mustache, and we did weird things. It was very, very odd, but very fun. We used to play tennis during our lunch breaks. We never played with Roger Federer, unfortunately, but probably a good thing. And then there's a random picture of a horse there. Some of you may know the game of horse if you play basketball, but essentially it revolves around throwing a piece of paper into a bin. And if there was nothing to do, we just played games. We just had fun. We also worked very hard. Steve and Hannah. But yeah, it was a really good and fun time. So just moving on to things that I've done to bolster my CV for education. So there's 3 things that I'd just like to sort of highlight. So something that I did during med school, something that I did during my foundation training, and something that I'm doing currently and during my CTF year. And I'll just put some sort of take-home messages that will maybe help you if you're thinking about applying for a role in medical education. So Shine and Yes. So Shine and Yes was something that I did during my university days. Shine was mentoring inner city primary school kids, helping with schoolwork, going into their schools and just sitting there chatting with them, spending a couple of hours a week and just helping with schoolwork or anything else that was going on. And Yes, it was a bit more challenging. So that was working with children that had been suspended or expelled from their schools for behavioural issues or anything really. And they tend to be more at secondary school level. And that was based in Camberwell in South London, which is quite a deprived area. And it was really interesting, sometimes very difficult. But what I would say is that teaching is teaching regardless, whether it's kids, whether it's adults, whether it's teenagers, you'll always gain something from teaching something to someone, because essentially what it is getting information, packaging it in a very simple language that anyone can understand and delivering that information. So I think teach is what I would say as much as you can, because for my CTF interview, I had to essentially give a 5-minute lesson on, I think it was hypothyroidism or something. And, having experience with teaching and knowing what works with different people was really helpful. And I think Olivia alluded to this, so feedback and reflection. So try and get lots of feedback forms. If you can't get lots of feedback forms, just, write about it and reflect about it, because often when people are looking, or employers are looking at your teaching experience, they often want to see that you've thought about what went well, what could have gone better, and how you will improve it. So I think that's something really important. So bleep test. So this was something that me and a couple of my colleagues did. It's an in situ simulation for final year medical students that we ran. Essentially what we did is we sort of commandeered some wards and some doctors' offices, Windsor Building at the Royal Infirmary. We got some bleeps, we got some junior doctors who volunteered their time. We got some medical students, not these medical students. And what we did is we gave them lots of different scenarios. We sort of bleeped them from ward to ward, gave them scenarios about dosing warfarin, a hyperkalemic patient, and they had to, read ECGs, prescribe medication, discuss with seniors, and lots of different aspects, documentation, all this kind of stuff. And we would bleep them across the different wards on the hospital to basically simulate what it's like to be on call on an evening shift. This is a bowl of ketchup. So we had a simulated patient, and the patient had the medical students will have to do an A to E assessment on a patient with hematemesis, hence the ketchup in a bowl. and so it was a very interactive, quite highly stressful learning experience for those medical students, and it was just really enjoyable to run, but also really sort of fun to watch, because it's essentially, you know, where me and my colleagues were at the beginning of our F1 rotation. But yeah, so it was me and two friends, and we, you know, sat down one day and was like, let's start this thing up, and we ran it with the help of some, you know, volunteer doctors, and you know, we got quite a lot out of it. So we were runners up in the UHL Innovation Ward, and we managed to get our abstract accepted for an international conference, and we presented there. We won a prize at national conference, so I think we got quite a lot out of it. It was a good idea, but I think what I'd say is that, you know, if you have an idea or if you want to do something, just do it. You know, take initiative. You don't always need sort of a senior member to oversee things. You can just you know, take initiative and carry it out. And we did, you know, recruitment. We secured the wards. We made certificates. We pretty much did everything. And that's what people found the most impressive, is that 3 junior doctors just did this. And so it's just about taking initiative and just starting something that you're passionate about. And so always try and adapt and improve, you know, the idea that you have, because if you want to get a publication out of it, if you want to write an abstract about it, you need to have it just something that's a bit different about it. So even before you start running your program, think about how you can improve it, and make it sound a bit different, so that, you know, your idea is already thinking about writing an abstract or submitting an abstract to a conference, is what I'd say. So yeah. And so the final thing that I did during my CTF year, and I'm still currently doing, is the HCA project. So essentially, we took 30 students in their first year and trained them to the competencies of healthcare assistants. And we wanted to assess the impact that it had on their medical training, so them at medical school, but also the kind of effects it would have when they graduated and were doctors on the wards. And we also interviewed the teaching faculty, and we found really interesting things about, you know, whilst this might help the medical students, this might also help the nursing staff, and the relationship between the nursing staff and the medical staff, so the doctors and the medical students, because there can be sometimes a bit of friction between the two. So some really interesting research with some interesting stuff to come. But yeah, so I collected some qualitative data through focus groups and interviews for that. And that's a skill within itself. I think that's something that I learned. And we've got 2 publications out of it, a paper to come, hopefully, and a lot more research ahead. And the things that I'd learned from this is, you know, MedEd isn't always about teaching. This had nothing to do with teaching. This was more about a conceptual idea, incorporating into professional education. And there was very little teaching in it. So, you know, if face-to-face teaching isn't for you, there's a lot more that medical education can provide. Another things is, you know, administrative things like starting a research piece, so writing the protocols, writing the interview questions, you know, getting ethical approval, asking for permission from the medical school, but also the trust. And I think something else that I've gained from this is qualitative data collection and interpretation. I think qualitative data is probably quite underrated. I think quantitative data tells you a yes or a no, but qualitative data often tells you a why and a how, or a why not. So I think it's quite important, and probably something that's often undermined. And the last thing that sort of is important is writing educational research papers. I think writing papers generally is a skill that you tend to try and hone, and it's only done by practice. But yeah. So my future plans. So I think I'll probably focus on my emergency medicine training for the next 3 years or so. I think I'd just like to focus on gaining the competencies. And there probably will be some informal teaching, but no formal teaching roles for me then. And then I'm not really sure. Ideally, I'd like to take a year out as an educational fellow, ideally in the emergency department, but it can be anywhere. Anything clinical would be great. And then the overall plan is to do sort of part-time emergency medicine and a more fixed role within education. is the plan. So, summary. So medical education is extremely challenging. You can be really creative, which is something I really enjoy, and it's very varied as well. I don't think there's not a one size fits all. There's no one way to get into medical education, but teaching fellowships are really helpful if you're undecided or you just want to start a bit sooner. I'd say teach as much as you can in any format, regardless of age, subject. Reflect and get feedback on your teaching, and try to always gain something from your teaching intervention. So whether that's presenting locally, trying to submit an abstract, or publishing your teaching. And I've just put 3 conferences that you can submit to. So DMEC and ASME are both national, and AME is an international. But yeah, great. Thanks for listening. Questions?
Thank you so much. I think what we'll do is we'll save the questions till the end, if that's all right. And we will move on to our next speaker, which is Hannah, who is a lecturer and I think also the head of the CTFs at the university. So she'll be talking to us next.
Yes, I will. I do have some slides, but they're more just to remind me of some things to say more than anything.
That's fine, that's fine.
So I don't know if you necessarily want to see them or not. Let me see if I can get them up. If not,
I'll just spotlight you so you don't have to, if you don't want to share slides, that's absolutely fine as well.
Yeah. I'll share them just in case you want to see them, but they're not yeah, they're not can you see that?
Yes.
Come on, Hannah. Oh, these old slides.
These old things I had just lying around.
Look how polished it looks. You have to did you have to remind yourself of your name, Hannah?
I did. That's why it's at the front. That's the very first thing, to remind myself to tell you my name. Although I do recognise a lot of faces as well. It's so nice to see all of you, including Kish. I didn't know you're going to be here. It's nice to see you. So I'm Hannah, a lecturer at the university, recent lecturer, well, recently in September. A bit about me. So I came to medicine, to Leicester, sorry, to study medicine in, should I tell you when? 2009. So I qualified and worked locally in Kettering and Leicester. And then I got to the end of my F2 placement and started working for the university in 2016. So I did what Kish was talking about. I did a clinical teaching fellow job. And really my main motivation for doing that was I came to the end of F2, I think similar to what Liv was saying. I didn't really know what I exactly wanted to do, but I knew that I wanted a break and just some time to think and plan my career a little bit. I was actually fortunate enough to get an academic foundation program, so I will talk a little bit about that later. But yeah, how and why did I get into medical education? Well, my first experience of education was actually as a medical student, as I'm sure a lot of you will have experienced as well. So I did, when I was in second year, I just did some informal teaching of my medic students. So we have medic parents at Leicester, for those of you, well, you probably know, but where sort of you adopt people in younger years to kind of show them the ropes. And so I did a bit of kind of revision based stuff informally, and just, yeah, a few friends that I made in a year below, we went through some stuff together. And then I did something called peer assisted learning program. I don't know if that still exists in Leicester, but it was essentially the same idea of peer teaching, but in a bit more of a formalized way. And I also taught in some revision societies and things like that. So throughout being a med student, I kind of liked teaching and enjoyed teaching. And also when I became a doctor, I really loved the patient education stuff. So being able to just sit down and say, do you know what drug this is and what this does? Or do you understand your diagnosis? Do you want me to talk through that with you a little bit? Like, I really loved that, being able, the rare occasions when I had time just to sit down with patients and do that. I found that really rewarding, and that was almost my favorite part of the job. And as I mentioned, I wasn't sure what I wanted to choose as a specialty. So really, I had quite superficial motives, I think, coming into the university as a teaching fellow. I was like, do you know what? I can't lose anything from doing this. If nothing else, I'll do a year. I'll get experience doing something a little bit different. I'll get some qualifications, and then I can always go back into clinical medicine if I want to. But it turns out I didn't really want to. I loved it so much that I ended up staying. And so that was my route in, really. I worked as a CTF for 2 years. Then I went up a grade to become what's called a lead teaching fellow, where I actually worked alongside Steve and took on a little bit more responsibility, working with the CTFs and taking over or co-leading units. And then, yep, in September just gone, I was promoted to a lecturer. So that's sort of my journey so far in education. And why do I like medical education? Well, I think it's really rewarding, as I'm sure a lot of people here today think as well. One of my favorite things was just sitting with a student. They'd come into a group work session, they'd be all confused, like, Hannah, I don't get it. And then you kind of talk through it and you just see the penny drop. They're like, oh, so that's why this happens. You're like, yes. And they're like, yay. And it's like quite a nice, rewarding experience when they happen. You don't always get them, but when they happen, they're really cool. You get a sense of helping others. So when I was a student, I know that there were times when I really struggled just learning medicine. As we all know, it's tough, isn't it? So actually being there in that supportive role, you get to help them, but not only then, you kind of have a big impact. So I've said here potential for a big impact. What I mean by that is that someone told me this once, you're not just talking to that person, you're talking to all of the people that they are going to come into contact with. You know, when you're imparting knowledge, that's for an individual, but that individual is going to take that. They might pass on that knowledge to somebody else, or they might use that with a patient one day. And so, you know, you've got 250 students that you're teaching. That's hundreds and hundreds of patients that are potentially going to be positively impacted by those seemingly small one-to-one moments you could have with a student, which I think is very cool. It's people focused as well. So that's why I went into medicine in the first place, because I just, as you can tell, love talking to people. So it's all about communication, and it's all about support as well, actually. That's how I saw the teaching role. It's not just knowledge based, but it's just life skill based as well, just kind of giving tips and tricks, or like, this is what it was like for me on the ward, or, you know, the kind of unspoken things that people don't often say. I found it an opportunity to share in that way. And as Kish mentioned, it's fun. Like, I just think it's really, really fun. It's an opportunity to be creative, as has already been said. And I actually really like that you can build relationships over a long period of time. So what I found working as a doctor, often you move around quite a lot. So until you kind of find your specialty and you find your footing in your permanent consultant job, often there's a lot of rotations around different wards or departments, or even trusts and locations. And I really liked that I could spend, well, I have spent years now with staff and colleagues, but even as a teaching fellow, spending a year with colleagues is actually really lovely to get to know people, and also students, as a lot of you here, like, I recognize a lot of your faces, and that kind of feeling of, oh, I remember day one when I saw you, and now look at you, you're graduating, and like that sense of following through over a long period of time, I think as well is really great. So that's just, I could talk all day just about this, but I'll stop there because you don't want to hear me rattling on about that. So a typical week, nothing is typical at the moment, as Kish said, but this is just some random thoughts I've put down in terms of how my week looks at the moment. So on Monday, often what I do is I prepare for the running of the unit. That looks like a lot of admin, putting together things up on Blackboard if they're not up already, meeting with the teaching fellows to give them briefings if they want them, to make sure they're happy with the content material. General admin, my life is basically admin currently. Yeah, but that plays a role. On Tuesday, that's when my unit runs. So in the morning, I try and be around and available to support the teaching staff, both the lecturers and the teaching fellows, doing the small group work, uploading resources after that's happened, and kind of following queries and questions on discussion board and things like that. Wednesday tends, I've put personal development here because I'm currently doing a master's. So I try and set one day or half a day aside to work towards my master's, and Wednesday tends to be the day that I do that, if I can fit it around other commitments and activities. Thursday is not limited to this, but just Thursday, but often we have our staff meeting on a Thursday. I try and set time aside to meet my tutees on Thursdays as well. And on Fridays, we have our weekly catch up. So as mentioned, I oversee our current CTFs. So we have a weekly meeting just to check in, see how they're doing, troubleshoot, and then kind of any points that come up from that, then I'll kind of help deal with that. So just to give you a flavour, it's quite varied in terms of time with staff, time with students, and it's not limited to that. So in the gaps, I'm preparing teaching material. I might be, as I said, answering student queries, delivering lectures, observing staff. So again, the CTFs, I do a lot of their observations, and I've actually been involved in teaching on their PG Cert this year in terms of small group teaching skills. General admin, had to put that in there, and research, as I mentioned, with my masters. So it's pretty varied in terms of, that's the kind of flavour of the stuff I do. I'm sure there's more, but that's just all I could think of off the top of my head for now. In terms of career goals, at the moment I'm happy with my level in terms of staying in MedEd long term and staying as a lecturer. I think it's a nice level where you still have contact and time with students. You're not so far up the seniority that you lose contact with the students, but it's a little bit more senior that I get to have that oversight and plan things as a whole. There's pros and cons. I loved the hands-on teaching of being a CTF, but this is a bit more organisational as well. But my main career goals are just to finish a few postgrad qualifications, like my masters, potentially work towards. So I have the FHEA that Kush was talking about, as he does. So potentially at some point work towards a senior FHEA, which is more to do with leadership and oversight in education and mentoring and that sort of thing. And then just gradually work my way up through university. That's sort of my non-specific plans for life right now. But as we know, anything can happen, can't it? So let's just see. So I was thinking about advice, and I think a lot of what Liv and Kish have already said is brilliant, and I'll just probably echo that. Take any opportunity to get involved in education. As Kish said, whether that's informal, you're just working with peers, or in years below, or when you get to work on the wards and you have medical students on your ward and you're in F1 or F2, just being proactive and taking time aside to teach. And just to encourage you, you don't have to know it all, because nobody does. So I think some people shy away from teaching thinking, oh, I can't possibly do that because I don't know enough. And I felt like that. I felt like I was a very average performer in medical school. I was like, what do I have to offer people? I don't even know if I really know that much myself. But as Kish said, it's an amazing way for you to learn yourself, develop your own communication skills. And actually, sometimes if you've worked really hard on something, or if you have had to find a way for it to make sense, that makes you a brilliant teacher, because you can communicate exactly the steps, the 1, 2, 3, 4, 5 to work through to understand something. Where sometimes people who instantly understand it, they're like, well, it's just because of this, it's obvious. When the students, they're like, is it obvious? I don't think it's obvious. So actually it's not a negative if you have had to work hard or find different ways to understand something, because you can share that experience, and that can often be really helpful for students. And to be honest, teaching is key to being a good doctor anyway. So even if you don't end up, as I think a couple of people have said, even if you don't end up like me doing full-time medical education, it's still important. Such an important part of being a doctor is teaching and mentoring junior staff. As a consultant, you'll have trainees under you that you'll be teaching and mentoring. So any opportunity you can get to build those skills early is never a bad thing. But if you do seriously want to consider it as a career, then, as has been mentioned as well, have a look into intercalating. Particularly, I know that Leicester are kind of starting up a MedEd specific, like you can do the masters in MedEd in 1 year. I'm sure there are other places that offer that too. So that will be invaluable as something to have on your CV if you're looking to do that. Consider AFPs, and I've said consider because I think it depends on what you do. So when I did my academic foundation program, I did it in leadership and management. So it wasn't really research heavy. It was actually just, it was about leadership styles. I did a little bit of a project, but it wasn't like a really intense 3 months doing like scientific research. It was like, oh, hey, cool, go here and do this and do a bit about leadership. Like, okay. That was actually, I found it fun and quite lighthearted. And took away a lot of skills for research, but also that helps me now. And so again, I just kind of thought, well, I'll just go for it. And it tends to be my approach to life. Like, let's just see what happens. So yeah, so consider it. It's not essential, but I think there are definitely transferable skills, not just in education, but in medicine as well. And I'm happy to answer brief questions about that at the end if you want, but it might have changed now from when I did it anyway, but happy to talk about that if you want. And then, yeah, just looking into postgraduate qualifications. As Kish said, a lot of places offer them as part of teaching fellow roles, if you want to go down that route. If not, and you want to do one or choose to do one in your own time, if you can't find an intercalated degree that you like or that offers that, there are other ways around it, but just kind of bear that in mind. Again, it's not essential, but it just, if you're interested in it and you love it, well, then why not? Because I think that has to be at the heart of it, really, like enjoyment of teaching. I think if it's just seen as a CV building opportunity, it will be fine, but it will, you know, it will mean more to you, I think, if you really enjoy it. So especially if you're thinking about taking a year out to do it. But as I said, I think teaching is something that is really, really important in medicine anyway. And that's basically it. So I'll stop sharing my screen and go back to gallery view so I can see you all.
Thank you so much. That was really nice to see how you kind of came into medical education. So like before, we'll just put the questions, we can have all the questions at the end. So we will move on to our next speaker, which is Dr. Jakes, who is a lecturer at the university. And I will just spotlight as well. And I think you're muted as well, Dr. Jakes.
Yeah, I've not used Zoom before to present, so I normally use Teams. What can you see the PowerPoint there?
Yes, we can, yeah.
But it's not very big.
If you...
Is that better?
I think if you start the slideshow, it will probably get bigger.
Slideshow. Yeah, right. Yeah, I'm showing my...
I think you might be sharing your actual page, Dr. Jakes, instead of your screen.
Yeah.
Well, let's right. I'm trying to find. So now if I go share screen, and there, right. Is that better?
Yeah, that's perfect.
Yeah. Okay. Right. So yeah, my name's Steve Jakes, and you know, thanks for inviting me here to talk to you all. I always like coming to things like this where there's lots of talks, because it reminds me what it's like for students. And I've just, as you get older, you develop a lower and lower tolerance for sitting down listening to people talking. And actually, I'm finding myself, you know, I was starting to struggle a bit there. So it's always great to have insights into what it's like for your audience, to be perfectly honest. Now, I didn't prepare any slides. And when we had Liv's lovely talk at the start, I thought, shit a brick, I better prepare something. So one skill that you develop as a medical educator is the ability to produce some kind of slideshow at very short notice. And so I was still listening to Liv, of course, and I was still listening quite enough to ask her a question on Anne Hathaway's cottage. But whilst I was listening to her, I was able to cobble together a few images. So what I'm going to do, I'm going to talk to you mainly about, this is going to be a sort of a biographical point of view, really. It's going to have nuggets of advice and things I've learned over the years, but I'm not going to try to enumerate those. I'm just going to talk to you in very general terms about my journey And I've got the email that I received from Devendra with those questions to answer, so I'll try to cover those as well. So yeah, I'm the head of anatomy here at Leicester Medical School. I think all of you know that. You know, I'm an anatomist, but I was a medic originally, and I went to Birmingham Medical School in the 90s. But we'll get there shortly. Now, we're starting off with the image on the top left-hand side. Can you see my pointer? Does that share? Does the pointer share? It does.
Yeah, I can see that.
Okay. Now, I can't. Now, this is going to be a classic kind of kid from a poor area does good story, because this house here, there was a house in this gap. Okay, so you got a house there and you got a house here, but there was a house there, and the estate that I grew up on as a child had a house that fell down a hole, because I was born in the Black Country, and in the Black Country in the West Midlands, there was a lot of mining activity, and we did occasionally have houses that fell down holes. Now, what's the message behind that? What am I trying to communicate to you? Well, the message is that my childhood taught me to be tough, okay? And to be a good doctor, you got to be tough. And to be a good teacher, you got to be tough as well, okay? I'm not saying I lived in mortal fear of falling down into a mine shaft all the time. That's not the truth. But, you know, the fact that you got the little shitheads down the road coming and bullying you and that kind of thing, it made you tough. Now, why am I saying you've got to be tough to be a doctor? Well, that's obvious, isn't it, folks? To be a doctor, you've got to be a robust character, okay? You can't be a shrinking violet to be a doctor. You've got to be fiercely aware of the welfare of your patients. You've got to want to stand up for your patients and do your absolute best. And frequently as a doctor, you've actually also got to stand up to combative colleagues who you might disagree with. And it's no different if you want to go into medical education either. And in fact, I would argue that if you want to be a medical educator, if you want to teach in medical schools, you've got to be even tougher than being a doctor out in general practice or on the wards, because students are very, very keen to point out your weaknesses, your inadequacies, and they will make you aware of that acutely. All right. So you need a thick skin to be a medical educator, all right? And this is a problem because so many of us, the ones of us who are attracted to medical education, we are inherently perfectionists, okay? We are obsessed with getting it right. We are obsessed with making sure that our students do their best, and we do our best for the students. And it can be a very difficult pill to swallow if they give you negative feedback. So develop a thick skin, be tough. Now, this next image here, some of you might recognize this. This is the slip road onto junction 9 of the M6. Okay, and I went to school just on the opposite side of the dual carriageway there. So I thank a lot of the kind of lead fumes which I will have inhaled from the M6 motorway as contributing to my career. Now, when I went to secondary school, that was where my teaching career started, actually, because our teachers were very, very stressed. Our teachers frequently took time off sick, and frequently I had to cover for the teachers. So actually starting from secondary school, and this was more towards the latter end of secondary school, I would often cover for the maths teacher, the chemistry teacher, and that kind of thing. And I had my own little following of all the swotty kids wanted to follow me, you know. But of course, the thing is, you know, like we've all experienced being the big fish in the small pond, the clever kid at the school. And then we come to med school and we discover that we're actually an average sized fish in a very large pond. Now, so that's another formative experience I had. Now, the historical stuff, and I don't know whether Olivia is listening now, but this character here is Sir William Bayliss, who was born in Wednesbury, which is where I went to school. And I slotted him in just to make sure that, you know, I kept up with all of you, because this guy from Wednesbury, from the Black Country, a very famous physiologist, actually, who discovered secretin and also who introduced the use of colloid fluids to treat shock during the First World War. So Sir William Bayliss, there you go. Anyway, that's got nothing at all to do with my career. So, you know, I said I was the clever kid at the school, that kind of thing. Well, my dad said to me, you're a clever kid, son. So you're either going to do medicine, dentistry, or law. He says, that's what clever kids do. So, you know, you get and do that. Okay, Dad. So I said, I'll do medicine. So, you know, I did what we all do. Got, you know, prepared, went and looked after grannies in nursing homes, that kind of thing, and got into medical school. So I got into Birmingham Medical School. And this is a picture of the main campus on Birmingham Medical School, which is an absolutely beautiful place. It's a vast campus, but you know, I had a really good time there as a medical student. And once again, you know, I came there, I didn't know anyone who was at medical school with me. I didn't have much in common with most of the people who were there. You know, most of these kids had come from private schools, that kind of thing, posh schools. So I tended to just sort of sit in the middle of the lecture theatre and keep myself to myself. The teaching I received as a medical student back in the 90s, to be perfectly honest, was poor. Was of poor standard. I look at the teaching that medical students receive nowadays, and you would not believe the quality of teaching that you students receive nowadays. You wouldn't believe the dedication of the staff. You wouldn't believe the amount of support that you get. And students don't always realize that. But when I was a medical student, you know, basically you'd have an anatomy demonstrator come in. They'd just come in from a night shift or something like that. They'd throw out a couple of dirty mnemonics, put their feet up on the desk, and that would be it. You'd have a guy come and give you a lecture who's much more interested in his research than teaching medical students. He'd give a lackluster lecture on laxatives and then bog off. So really, Leicester medical students have got a tremendous education. I honestly think that, because our medical school is made up of people who are dedicated educators. Okay, we want to educate, and that is our job. We are primarily educators, teaching focused. I did an intercalated degree as a medical student as well, and I know that Hannah and Kish mentioned intercalations as well, I think. And my intercalation was in gene therapy. So I did an intercalated project looking at gene therapy vectors in order to deliver growth factor genes to neurons. And that comes up again later on when I did my PhD. It's quite amazing, actually. Back when I was doing my intercalation and PhD, people were, you know, they were saying, you know, this gene therapy, when's it going to be used? And we were saying, well, we don't really know. It's all very novel. We're just using it in animals. And now look what's happening. We're in the middle of the biggest ever gene therapy experiment, aren't we, with these COVID vaccines? Because these are gene therapies, these are viral vectors or mRNA. So it's quite amazing to see it come to fruition. So there I was, you know, the kid done good. I did this intercalated degree, and then I became a clinical medical student. Now, when I was a medical student, we wore white coats. Okay, it was fantastic. You know, you had this white coat there. We would never be cocky enough to put the stethoscope around our necks, though. This isn't me, by the way. We always put our stethoscope in our pockets. So you had your stethoscope in one pocket, and then you had the yellow book in your other pocket, the Oxford Handbook of Clinical Medicine. It was brilliant having white coats. You don't have them anymore, sadly, but you know, that's infection control for you, isn't it? So clinical medical student, to be honest, as a medical student, I didn't really do anything like what you folks do in terms of career development. Okay, no one was really interested in any of that stuff when we were medical students. And it's incredible now, you know, you're getting publications, you're doing all this stuff. But I was just glad that I was passing my exams and able to progress from one year to the next, because the amount of stress that we experienced, I think, was far less than what you have to deal with nowadays. Okay, I think that the pressure on you all as medical students and juniors in terms of your career is unprecedented. And that's a sad thing in a way, to be perfectly honest, because it does detract to a certain extent from proper doctoring, if you know what I mean. You know, you can do all the bloody audits in the world, but that's not really proper medicine to my mind. So there I was, keen medical student. And when I graduated, I took the white coat off and it was just a shirt then. Okay, a poorly ironed shirt. In fact, the shirt might not even have been ironed at all. I got some good ones from Marks and Spencer's that you just hung up on a thing. Anyway, so I then worked for a couple of years in Birmingham hospitals, the Queen Elizabeth Hospital in Birmingham, the old Queen Elizabeth Hospital, and Selly Oak Hospital in Birmingham, which has now been knocked down. And it wasn't long before I went from this to this. Okay. So here, you know, this is me in the middle of my second year as a junior after graduation. And I'm looking, well, it's not me because it's a woman, isn't it? I'm looking dejected. I was starting to feel that morale was very low. The NHS felt like a pretty bad place to work, to be honest, at that time. There were major changes taking place in medical training. And really, you know, it was starting increasingly to look like this wasn't for me. You know, and it still remains the same today, to be honest, you know, in terms of morale, that kind of thing. And at that time, you know, I had a lot of thoughts going through my head. What will the parents think? You know, not that they'd really invested all that much in me, but what a big disappointment am I going to see if I leave medicine? What's everyone going to think? They're going to say, oh, it's such a shame, you know, you could have done so much. All right. So I've got all these conflicted thoughts going through my head. And that's something that a lot of you might think about as well. If you're thinking about a major career change or a move into medical education, say, from clinical practice, you know, you might have to deal with pressure from friends and family in terms of, you know, making you feel guilty for making that move. So be aware of that. But anyway, I thought enough is enough. And, you know, I thought I've got to do something about this. I don't like the way things are going. I've always had this interest in teaching, and I've always been fascinated in the basic science. So I approached my former PhD supervisor. I said, you got any PhDs? She says, yeah, as it would happen. Yeah, we've got a PhD project that you can be involved with as a named student. And so I got on to do a PhD in central nervous system regeneration. And that was a serendipitous moment. And in all of our careers, there's always been luck. Okay, you make your own luck, but still you need a little bit of help sometimes. I've got my eye on the time, don't worry, I'm not going to bore you all for ages. But I got on to do this PhD, and it was there really that this idea of a career in education started the seed started to be sowed, really, because I was exposed to some incredible academics, some amazing researchers, some incredibly clever people who were brilliant teachers as well. And so that was really part of the making of me really doing this. And it was good because at the same time I was able to fudge a bit of a dodgy deal with the local hospital where I maintained an honorary contract with the neurology department. And it meant I got paid as a clinical research fellow. So I got paid a lot more than your standard PhD student. So there's got to be perks to being a medic, haven't there? So I come to the end of the PhD. I thought, well, what shall I do? I thought I don't want to do research because that's a crap career, to be perfectly honest. Professional science as a career is very, very stressful. It's a succession of temporary contracts, no stability for years and years and years, horrible, difficult work, okay? And so I thought, well, teaching, okay? And that's what I've always been interested in, teaching. So let's be an anatomy demonstrator. So here, you know, this is just to give you an idea. I was an anatomy demonstrator at Birmingham. Birmingham, with its terrible reputation for anatomy education, due to poor facilities. We had very poor anatomy facilities there. And this was the making of me as a teacher. Because, you know, like at Leicester, you've got the dissecting room and all that kind of thing. And it's a great resource for learning. At Birmingham, students had me and a whiteboard with a couple of bones. And so that was the making of me as a teacher, because I had to be creative. I had to actually develop a narrative which I could talk through the students with. Furthermore, and this is something for those of you who are thinking of being CTFs, the CTFs at Leicester get fantastic support from the academics in terms of briefings. The academics make sure the CTFs know exactly what they need to know to teach. When I was an anatomy demonstrator, I never saw an academic. At the start of the semester, the boss would come and drop a massive pile of paper on our desk. This is what you're teaching. No answers, nothing like that. Get on with it. So we had to go and learn the stuff from scratch and teach it. So that was the making of me as a teacher. And I did that job for 4 years. Now, next, here's my children. Okay, so there's Thomas and there's Isabel. And I haven't put these images here just so that I get a kind of, okay, a lot of people do, don't they? They put a picture of the bloody dog or something like that, just so that everyone can go, oh, aren't you wonderful? You've got a dog. Hoop-de-doo. Okay, what I'm trying to communicate to you here is that the career that you think you're going to have now will be very different to the career that you will end up having. And that is because when these things appear, okay, if you have children, you might not wish to have children, and that's fine. And in fact, that you're very sensible if you don't. When these things appear, they change everything. They fundamentally change the way that your brain works, okay? And your priorities change completely. So up until then, it was career, career, career. I'm going to be the chief medical officer or something like that. But when these come along, it's fuck all that. The kids are the main thing. You know, I need to think about, is the career everything? All right. And I'm saying this because what's very important is that medical education is a career which can offer wonderful flexibility to you. Okay. So these kinds of jobs, oh, look, there's Hannah's cat. These kinds of jobs can offer you fantastic flexibility, and they're very family friendly jobs. So just be aware of that when you have a family, when you have a partner, things can change, priorities can change. So the kids came along, and then a job came up at Leicester. Okay. My wife's originally from this part of the world, and she wanted to come back to be closer to her family. And I thought, well, there's this job there. It's a senior lectureship. I thought, I'll never get it. I'm nowhere near experienced enough. So I came for an interview, not at the George Davis Centre, but at the MSB. And then this guy, Nick London, interviewed me, and a few other people, Laura Mongan. That's one of the kids. And I was able to bullshit them pretty well, to be honest. You know, I was able to pull the wool over their eyes, convince them to employ me. And so, you know, I got the job. Turned out that Mark Hamilton was going for exactly the same job as well. So me and Mark Hamilton were competing against each other for the same job. I'm probably not meant to tell you that. But anyway, got the job as head of anatomy. And the rest, you know, most of you really know my trajectory from that point forward. You know, I love teaching in the dissecting room. You know, there's no better place to teach, to my mind. And I know that things changed a fair bit when I came in compared to what was happening before. You know, I wanted to introduce new dissections, that kind of thing. You've got to be brave to be a medical educator. As you've said, you've got to be creative. You've got to be willing to actually grab the bull by the horns, fight your case, that kind of thing. Other things I've been involved with, well, of course, technology. Another thing about, you know, going out there and getting it, 3D printing, no one showed me what to do. I had to learn how to do all of that from scratch. I didn't know anything about it 2 years ago, to be honest. So I went and learned it. It's the same with all the 3D stuff I'm generating at the moment. You know, I know a little bit of photography, but I've had to teach myself all that stuff. So you've got to be willing to, you know, follow your interests, learn new things, be a constant lifelong learner. Okay. And that's very important as well. You only will be able to empathize with students if you yourself are learning throughout your life, if you never forget what it is like to be learning something new. Okay. For example, at the moment, I'm relearning how to play chess. So it's been 25 years since I played chess. And so now I'm going through the painful process of relearning how to play chess and getting absolutely destroyed by little children. Okay. So you know, make sure that you're always learning, and it'll give you great insight into what it's like for your students. And finally, I'm now involved in something called the Institute of Anatomical Sciences, which is, you know, I'm the president of that organization. And this is an area where we're always looking for input from medical students and young doctors who might want to present or, you know, come and talk about their work. So that's a plug if any of you want to come and join the Institute of Anatomical Sciences. So I hope that was relevant to what you wanted to hear. And thanks for inviting me.
That was great. Thank you so much. I think that answered most of the things that we asked for. But now that all of our speakers have given their talks, we're open to questions now. So you can either turn your mics on and talk, or alternatively put them in the chat as well.
I might kick it off, actually. I've got a little question. Kish, you mentioned something about the Fellowship of HEA. Is that the same thing as Higher Education England, or is that different?
So as much as I understand, I think maybe Hannah or Steve might know a bit more, but it's higher education academy, and it's essentially a nationally and internationally known teaching standard and framework.
It's called Advance HE now, isn't it?
Yeah, that's it. They've changed it.
I think most PG certs as well in medical education also offer the kind of dual qualification with the accreditation of from the whatever they're called, those people. So they come alongside. It comes alongside if you're doing a PG cert or part of your masters towards it, then a lot of the institutions offer them alongside it, or you can, I think, as Kish did, do it independently.
Yeah, I think they try and align it so that you hit the standards that you need to hit to get the accreditation.
Oh, we've got a question in the chat. Harpreet says, "Hi, I really enjoy the presentations. Thank you. How do you improve confidence in teaching others, especially if you don't have much experience?"
So Harpreet, do you mean confidence in your teaching? How do you become a more confident teacher? Is that what you're asking? Yeah. Okay. I think what gives you confidence in being a teacher is knowing what you're talking about. That is the absolute key to being a confident teacher. You know, you can be as confident as you like, you can bullshit as much as you like, but the students will find you out. Okay, so the absolute key to being a confident and good teacher is to really be very, very familiar with your subject matter.
I'd echo that completely. And I think the other thing to think is the other bit that always gave me confidence is that, yes, I'll need to review that and look over that information, but at least I've learned it once. A lot of the people that you'll come across or that you're teaching, sorry, I've got a bit of a needy cat behind me, but a lot of people are going to be brand new to it. And so actually anything that you can give them is helpful. That certainly gave me a lot of confidence, is kind of appreciating that. I think, as Steve said really well, it's, you know, it's remembering what it's like to come at something new and guide people through that way. So any experience that you can share of how you learned something, of, oh, this, do you know what, let me look it up. This is sometimes what I say to our teaching fellows, is that if you don't know the answer to something, how you look it up and how you find out the answer is in itself an amazing teaching opportunity in terms of modeling what to do when you don't know the answer to something, because there will always in medicine be something that you just have never come across before, that you don't know the answer to, that it isn't necessarily a right answer to. So kind of how you deal with that uncertainty and how you kind of learn yourself by looking things up and bringing students in on the journey and showing them how you do that is just as important as the knowledge that you impart as well, I'd say.
Yeah, I think I'd also add, you know, another thing would be considering the audiences that you build your confidence with, in a way. You know, we're all, I guess, slightly more confident in presenting in one way or another, maybe teaching large groups or small groups, for example. I know for me, I was actually a lot more confident teaching large groups than I was teaching small groups, where I felt that, you know, my teaching efforts might be more scrutinized by a smaller group of people, and therefore I was a bit more vulnerable. So I think, you know, explore that, and whether or not actually to try and build your confidence up, you know, start in your comfort zone and then work out of it. That always worked well for me. I mentioned at the start of my presentation, the way I got into doing them was kind of an audience that I felt that I was going to be kind of most relevant to. So at that point, I felt, you know, that teaching aspiring students was quite a good way of starting off that process, because their knowledge base was significantly less than that of the current medical students, and therefore I didn't feel quite so kind of vulnerable in terms of my teaching. And that was then how I built it up. So as I kind of got more experienced, I moved towards kind of closer and closer audiences, and now, you know, then you get comfortable teaching audiences that might even be people who are senior than you, you know, and that's quite a good way, or one way I found, of building up my confidence.
Yeah, I think just to add to that, I think knowing the theory is always really important, but also practicing how you deliver the theory or the knowledge because there's certain ways of saying things that will help students understand things better. And the other thing is, if you don't have much experience, sometimes it's, you know, going in as prepared as you can and then just taking the plunge, because that is what reflection is, you know, figuring out, oh, actually, I couldn't explain this very well, going away, thinking about it, thinking of a better way, and then coming back. So eventually you just have to take the plunge and go for it. And that was what it was like when I taught my first session as a CTF, and it was like that for a lot of my colleagues as well.
So sort of going back to that reflection that you mentioned, for each of you, obviously you've had varying lengths of careers in medical education. What are some of the things that you've adapted from the beginning of your thing, and what are some of the things you've learned and reflected on throughout?
I think a key thing I've learned is that less is more. And I think this is a very, very difficult lesson for us all to learn. I think when you start off in your career, you think back to those lectures that you had as a medical student where someone lists everything and there's 6 gazillion slides, okay, and you think, well, that must be good teaching. That's terrible teaching, to be perfectly honest. Less is more. And what you learn as you become an experienced teacher is what is relevant, what is important. And you also learn to trust your students, because there has to be an element of trust with students. You know, I have to feel able to trust students such that if I say, go away and read this, go away and watch this, I have to feel that I can trust them to do it. And I think that's key. Less is more. Distill down the stuff you're trying to teach. Think about, what I always think about is, you know, I would like to think that a lot of what I teach, students will remember after they graduate and even for the rest of their lives. And you've got to think, if I'm teaching such a minute little detail that I know that none of them are going to remember it 2 weeks after I've taught them, let alone 2 decades, you've got to think very hard about whether you should be teaching that in the first place. And now this also harks back to how we as academics and how you as prospective academics interact with the faculty of a medical school. And, you know, you have to be prepared to, as I say, have these fights. You know, a lot of being an academic is often having fights with people. Obviously not physical fights, I'd beat most people, but, you know, fights with people, intellectual fights, standing up for what you believe in, okay? And that can be, so for example, you know, there's a lot of inertia in medical schools around, let's take the topic that Hannah teaches, which is musculoskeletal anatomy. So there's a lot of inertia in the curriculum, which is, well, students have got to know all the muscles, all the origins, all the insertions and that kind of thing. But someone like Hannah probably is thinking, well, actually, do they need to know that? Is it enough for them to just know that this is a compartment? You know, do they? So I think less is more is my message.
Sorry. I think one of the things that I learned quite early on when I was teaching at university was that I think there's a big emotional, holistic background to when a student learns best. And so understanding the context, understanding their sort of their position, even outside of medicine, what's going on with them in general is something that was really important for me. And getting the best out of a lot of students is often, you know, finding out what works, makes them tick, finding out what they are good at, what they're bad at. I think getting to know a student, I think this works better in small group teaching, but I think that was something that I really reflected on when I was working with teenagers in London. I think that was something that I really reflected on and got a lot out of. Go for Anna, sorry.
No, it's good. It's really good. I think the biggest thing that I learnt is the spotlight is not on you, and it shouldn't be on you, actually. The spotlight, sorry, my cat's just knocked something over. The spotlight should be on the student and what's going to be in their best interest. Because I think a lot of the nerves comes from, I have to know everything as the teacher. But actually, as soon as you move that focus off of yourself and onto the person in front of you and just think, what are they struggling with? What are they actually asking me here? It's not about as Steve said, it's not about here's all the stuff that I know, I'm going to tell you all about everything that I know. Sometimes that can be our comfort zone, but actually it's not about, oh, look how much stuff that Hannah knows. Like, it's never about that, because Hannah doesn't know that much. But it's kind of thinking, what is the importance here? The importance is, how can I talk to this student in a way that they are going to understand, so that it's going to make sense to them? So that's my biggest reflection. And what I would always encourage you to do is just think about the needs of the person in front of you. As Kush said, that might not be knowledge, it might just be support and reassurance. But actually, even when it is knowledge, it's about drawing it out of the individual and starting with what they do know and helping build their steps and guide their steps to get there, so that they're going to remember it more, and asking questions more than you're answering, if that makes sense, to try and draw stuff out of students. Because as Steve said, students are in this context are adult learners, and they come with a wealth of knowledge and experience already. And so it's kind of drawing on that and focusing on that.
And apologies if I'm butting in front of anyone else, but I just didn't want to forget this point, which I probably have. Oh, yes. An important point is that, you know, we all think career is always about progression. Okay, career isn't necessarily always about progression. The sad thing when it comes to education, and I know this looking at a number of professor colleagues, for example, is that when you become a professor, you might think that's the top level of education, but it's not, because you hardly have any contact with students. The most fulfilling education is the proper shop floor education, the stuff going on at the bedside, the stuff going on in the classroom, in the dissecting room. So don't always think that you've got to be inexorably climbing up the greasy pole. You have not. If you find yourself a niche and you're happy with that and you feel you're making a difference, stay there, okay? Because, you know, you've got to strike that balance. You've got to hit that optimum, really, of job satisfaction and stress, if you like, okay? And you don't want to have gone into this career as an educator, loving interacting with students, only to discover, yes, I'm earning all this money, but I'm not doing anything that I enjoy, really. That's not what you should be aiming for.
Can I follow that point on with a question, if that's possible? I apologise for butting in, but it just fits really nicely with the question that came up. And it's actually a question for Hannah, because you spoke quite a bit about, you know, the fact you enjoyed when you were a junior doctor, patient communication and educating patients. I suppose as someone who's a couple of years behind you in terms of my kind of medical education journey, I wonder, you know, because, you know, people who enjoy education inherently enjoy communication, they inherently, you know, and they value that and get a real buzz out of communicating with patients particularly. Do you ever miss that side of things? Do you ever miss clinical education? Because I think for me, that's been the big kind of, you know, thing that restricts me making the jump and saying, actually, sod it, I'm going to leave and do MedEd because I love it.
That's a really great question. And I think the answer is going to be personal. For me, as in not personal like oversharing, but personal as in personal to you. Not like a heads up, guys, this is going to be really personal. No, I don't miss it. Partly because I just felt it wasn't worth it. Exactly what Steve was saying. I felt like the snippets of job satisfaction that I got when I was able to sit down with a patient was far outweighed by all of the other stuff that you have to deal with in terms of the admin and the legwork and running around and the stresses and pressures of being on a ward or a GP practice. For me, the balance was just off. And because that was my favorite part, was just sitting down and being with people, it's like, I just saw it as such a gift when I was a CTF. I was like, I've got 2 hours. No one is going to interrupt me. Like, no one's going to like knock on the door or barge in being like, you need to prescribe this, or you need to order this scan or chase this up, or who's doing this. I was like, there are no such things really as a medical education emergency. Like, I'm not going to be interrupted here. I've got 2 hours to give my undivided attention to these students and do nothing but sit and talk to them and educate them. That to me was like a breath of fresh air. But I appreciate that won't be the same for everybody. But personally, that was my experience and a big driver as to why I wanted to stay full time in education. But there are people, so for example, my husband, he is also, He's a paediatric registrar. Some of you may have come across him. But he does both. So he has done less than full-time training in paediatrics so that he can do essentially a 60-40 split between clinical and education. And he works down in our simulation suite. Yeah, if you've not met him yet, you probably will, those lesson med students. But yeah, so it's always possible to do both. And again, that was just a decision that he made. He just wanted to do less than full-time training because he wanted to do more education. So he sits on the other end where, yes, he did miss that patient interaction and wanted the best of both as far as he could get it. But for me personally, no. And that was part of the reason I stayed, as I said, because I almost went in asking that question. Like, if I miss the patients, then that's a big, selling point to going back into clinical education. But I didn't miss it. And so that was almost a big motivator for me to stay full-time in education. But as I say, that's not necessarily everyone's journey, but that was my experience.
And not to forget as well that even in someone like me, I've still got opportunities of doing clinical teaching. So I've taught on our CHDD course, which is a little clinical course that second year medics, first and second year medics do. And I really enjoyed that, actually, going out onto the wards and, walking up the stairs while the students were huffing and puffing behind me after the third floor and saying, you've got to be able to do this sort of thing. So, yeah, you can still do that.
Sign me up. You've sold me. I'm out of here. I'll go onto the wards when I'm on call this weekend and be like, so long, guys. You're not seeing me anytime soon.
I think for anyone that's interested in mixing the two, I think something really nice that happened after I finished my year of teaching, I went back to the wards, like a bit anxious actually, like, oh, I must have forgotten so much, but actually I was just really like refreshed. Things came a lot easier to me. My mind was a lot less fatigued, and I think having that space and having something different, and something that a lot of other sort of more senior clinicians tell me is that, having just something different to focus your mind on is really nice. So, if you don't want to go all the way one way, it's nice to have the mix if you're that way inclined as well. And I think it complements both quite well if you manage your time well.
I think it's been really nice seeing sort of the broad spectrum of things. Like on one hand, we've had people that have chosen pure education. And like with Kish, you've got, you've chosen to go into ED, whereas Liv, you, like most of us, are sort of stuck in the middle, bless you. So we've got another question in the chat saying, how do you improve the application of learning?
Nikita, I'm not entirely sure exactly what your question is asking. Could you come on and on the microphone and just elaborate a little bit on your question for us?
Hi, can you hear me?
Yeah.
Sorry, I was just moving away from a noisy environment, so you didn't have to hear anything. So the question is relating to how, when you learn something for the first time, like how do you know whether you can apply it or not correctly? So you know how you have the knowledge, but then you sort of have to progress to the next step of being analytical about it or critical about it, and then being able to apply it to real life context. How do you know whether you've mastered that or not? How do you improve on that skill of application?
I'm not entirely sure precisely what you're asking, but still I'll try. I think you know by receiving feedback from people. You learn whether you can do it by doing it and getting feedback. I think that's the key thing. But maybe others have understood the question differently.
I'm wondering whether or not you're thinking along that kind of, processes of learning and kind of moving up the hierarchy in terms of what we value as a good learning experience. And the top of that, I think, is innovation and kind of, actually creating something from scratch. So, and we know that things, for example, like teaching others, if you're able to consolidate your learning and translate that into something new or something creative, then that certainly helps with the learning process. But I mean, I guess my point would be, it's different for everyone, I suppose. There's an element of personal confidence with things. Take, for example, a clinical skill. What one person might view as having mastered the clinical skill may be completely different to what another person views as mastering that. For example, if someone you might have a particularly confident person who views themselves being competent after 1 or 2 attempts. Someone who may also be equally as competent and equally as skilled in that area, but their own self-perception of that skill might mean that they feel that they need further practice and further reflection before they deem themselves to have mastered something or to be competent in it. So I think it's a very subjective thing, really. I mean, I don't think there's one right answer, I guess, for everything, because there is that inherent kind of subjective thing, a very personal aspect of learning that you can't always just get from things, as Steve said, kind of with feedback and stuff. That's a bit more objective from another person, but there is definitely that kind of intrinsic side of things, which I think is also important.
Yeah, and I think if I've understood it as well, I think partly a good tip or piece of advice is just to get around people who are slightly more further along than you. So, for example, that could be a more senior medical student, that could be a junior doctor or a registrar or a consultant, and actually talk some of these things through. That it kind of links with feedback, I guess, what Steve was saying, but I think it's rather than, so a classic example of this, I think, is ward rounds. I remember being on so many ward rounds as a med student and just drifting through them and not really having a clue what was going on. They were like, do this, do this, do this, do this, next. And I'm like, oh, okay, next. So actually kind of maybe not in the middle of it, but afterwards, just making a note of a couple of things and talking to the registrar or consultant or junior doctor and just saying, why did you start this medication? Or why are you ordering this test, this CT scan? What exactly are you looking for? And actually hearing people kind of verbalize their problem solving process or their application process can actually really help you, so that you can think, oh, okay, so I have knowledge of diuretics, for example, but to apply it in this patient in front of me, this is why that's the best choice. And kind of, I don't think you can ever know everything or be able to apply everything. I think it's a continual journey that you will do, but I guess that's a great piece of advice for your continual learning, is just to talk things through with people and ask loads of questions, and so that, or even just say, this is what I thought, can I just clarify, like, this is what my line of thinking is, this why you're doing it? And kind of just having those kind of conversations, I think is a good way to learn, particularly in like a clinical context, but it can apply to anything, I suppose.
And to reinforce what Hannah said, we talk about teaching, it's teaching and learning, and it's very easy to perceive the process, teaching as being the unidirectional flow of information from the master to the apprentice sort of thing. But teaching is about a dialogue. Okay, and I keep telling this to my students. So I teach neuroanatomy, I teach neuroscience to students, and I keep telling the students, let's engage in a dialogue. I am more available to the students than I have ever been. So with the online delivery, I'm available every afternoon that I teach for 4 hours in a troubleshooting room, waiting for them to come to me with questions. And very, very few come. And I keep saying, come and engage with me, come and talk to me. And I think there's a fear amongst students. I think you're scared of asking what's perceived as a stupid question or something like that. I get a lot of apologetic approaches from students. Oh, I'm terribly sorry, but would you mind? And I say, don't apologize. You're my job is to help you, sort of thing. Likewise, if you're a medical student, your job, the job of the people who are on the wards is to train you. Okay, if you don't get trained, then we ain't got another generation of doctors. So if somebody resents you asking a question, then they're in the wrong job, full stop. Okay, so have the confidence to ask questions, have the confidence to ask silly questions, because then you can dissect down to whether you truly understand something or not, if you engage in that dialogue.
Someone once said to me, actually, just to pick up on that, that if you don't know the answer to something, then it's not a stupid question. One of my consultants said that to me. He's like, if you don't understand the process of why you're doing what you're doing, then I want to know about it, and I want to help you understand that, because that to me is more important that you actually understand the why or the how of what you're doing.
Hannah, there are stupid questions. I was asked by a student. They says, I've heard, is it true that oxygen does not cross the blood-brain barrier? And I replied and says, think very carefully about the question that you just asked there. So there are such things as stupid questions.
On it, yeah, okay. I guess what he was saying was, in terms of clinical stuff, rationales and things. Yeah, I hear you, Steve, though. Actually, do you know what he said? He said, ask me anything, but try and only ask me once. And what he meant by that was, early on in the job, there's going to be a lot of new stuff. There's going to be a lot of things going on that you don't understand. And I'm really happy for you to ask me anything that you don't really get about how this works, but try and actually retain that and learn from it so that you become more independent. Because I think this is it. It's a journey, isn't it, really, of going from more dependent to less dependent as a medical student, and in life in general. Like, there will be a time in med school when you need to be more dependent, and you need to have your hand held a bit more. But the end result is not knowing everything, but the end result, I think, is becoming more independent and more confident in how you find things out and figure things out and learn. And actually, there'll be times when you need more hands-on support. Even as a registrar, there will be times when you need more hands-on support, and there will be times when it's a bit more hands-off. So that was an approach or advice I found really helpful, was ask anything but try and learn from it. Just ask it once, so that you can, the aim, like when at the end of a placement, is that you're more independent than you were when you arrived.
It's been very formative for me doing homeschooling. Now, I don't think anyone in the audience has children. I'm sorry if any of you do, but I don't think anyone does. And homeschooling is the most incredible learning experience. I thought I was patient, but I'm not patient. When you've sat down with someone over, what do you mean you can't find cat in the dictionary, sort of thing. Yeah, that's a real test. That is a real test. So if any of you want any proper experience in education, just contact me, and you can come over and sit down with Thomas for the day, and you can go over stuff with him. I'd be very, very grateful for that.
On that note, I think I'm very aware of the time and the fact that we've run 55 minutes over the end of the slot. But to be fair, this has been, I think for me, even having helped organise it, this has been really, really, really useful. So thank you very much to our speakers. If you guys have any more questions, feel free to ask, but I think we should wrap up at some point soon. People want to go. If I could ask, actually, before people do run off, I was meant to do a little cheeky plug. So the MedEd Society has got a peer teaching scheme program sort of thing up. So if you guys want to teach something, we are available to provide that platform for you. So I'll put the Google form just in the chat now, if I can find it on my many tabs. There we go. The Google form's there. Feel free to fill it out. Just put on a couple of little topics that you feel like you want to teach, or something that you've just learned and you like to go ahead with. You can take some of the tips that our lovely speakers have given us today. So yeah, feel free to fill it out. If our speakers could stay for like a couple of minutes, I think the committee's got a couple of questions for you, but everyone else feel free to go ahead. Thank you very much for coming.
Yeah, and if anyone wants to contact me, I'll very happily speak over Teams or anything like that. I'm sure that applies to everyone else as well who's spoken. We'd very happily talk to you over the phone or whatever, in any format. And you're welcome to come down to the dissecting room, and I'm sure Hannah would be happy for you to be involved in group work for the first and second years if you were keen.
Oh, also, Another thing, just reminded, we've got our first event tomorrow of the peer teaching scheme. We need to come up with a better name actually. So Hamza, who is a first year, he's actually been very brave and he's doing a teaching session on the lumbar spine. So if you guys want to do any MSK revision, you know, Steve and Hannah, if you guys want to do any MSK revision, feel free to come along. It's at 6 p.m. tomorrow. The Zoom link will be sent out via our social medias.
And on Anastomos, I think.
And on Anastomos.
But yeah, thank you everybody so much for coming. I hope that our attendees found it useful. I mean, I found it really useful. It was really nice to hear about all of your careers and how you've got to your point and that you are at. But yeah, I hope everyone else has a lovely evening, and yeah, we will just have a quick chat with our speakers.
I think that's everyone.
Yeah, that's everybody, yeah.
Fantastic. So I sent out an email a while ago to our Leicester speakers. Liv, I've not sent this out to you, but if you'd like to do it, feel free to. So on our Instagram page, we thought of putting out some like little quotes and snippets of a conversation from medical educators to students. It's quite an accessible platform for people. Most people have got an Instagram nowadays, especially like the newer recruits to med school. So I thought it'd be a really good way to put it out. But if you guys, if you have any specific quotes that you'd like to send us, what we thought of doing was trawling through the recording of this and maybe taking some snippets out of this as well. If you're happy for us to post them, that's fantastic. We'll likely email them to you beforehand just to make sure you want to see if you want to change anything at all.